A diagnosis of dementia is life-shaking. It impacts not only the patient, but those around them and grows worse each day. Dementia comes in many forms. Tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. Dementia is sometimes thought of as losing ourselves, who we are, our memories, and our relationships with families and friends. It's one of the most feared diagnoses of the boomers, or those older than boomers as we age. First, let's take a look at this week's Prairie Doc quiz question. The most common cause of dementia is, number 1, vascular-induced dementia, 2, Alzheimer's disease dementia, or 3, senile dementia. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We will announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. But we answer your questions about dementia through the whole show as they're called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight are Dr. Robert Nuss with Avera Medical Group University Psychiatry Associates, Sioux Falls, and Dr. Jeff Boyle with Avera Medical Group Neurology, Sioux Falls. Thank you both for joining us. So it's a special pleasure, instead of having just 2 neurologists, now that's not a just, but we have a psychiatrist and a neurologist, and I mean different perspectives on the same thing. So I think it's a special night with special experts. So tell us a little bit about your practice. Bob, let's start with you.
I do the inpatient geriatric psychiatry for Avera. So we've got a 14-bed locked unit that is actually located on the Prince of Peace nursing home campus there. We're still considered an acute hospital,
yes.
But that's where we're located. So 14 beds there. You know, it's geriatric psychiatry, so I see a fair amount of depression and bipolar and schizophrenia. But I get a lot of dementia with behaviors, and it certainly is, without question, a difficult and challenging disease process to work through.
Tremendous. So your expertise in psychiatry is geriatrics in general, isn't it?
That is a majority of what I do, yeah.
So that was what I did too, most of my life. And if you think about it, and general internist does a lot of psychiatry.
Oh, without question.
It's part of our lives too. Now you're a neurologist, a general neurologist with an expertise in sleep apnea.
Yep.
As we learned last time you were our guest here. So tell us a little bit about that kind of a practice in dealing with dementia.
Well, I see a lot of older patients, and sometimes they do come in with memory impairment, and whether it's early on in their process or later, it's a different approach at every stage, and there's quite a lot out there. It's not an uncommon disease, and so it's a big part of my practice.
So I see dementia as one of the most devastating diagnoses. I mean, I've lived with a cancer diagnosis. I've seen people with diabetes and with, severe COPD and lung disease. But when you have dementia, it's like somebody's robbing your family member and stealing him or her from you, and you can't seem to do a thing about it. What's your take on the severity of the devastation of such a thing?
Well, it's certainly at the heart of what it is to be human, and your memories and your personality. And I mean, some people, it's their speech that's most affected, and it's progressive and relentless, many times. And we don't have a good treatment yet. So it is, is a quintessential disease that we need to be, more aggressive in finding a treatment. And
we don't have good treatments at this point. Bob, talk about that whole issue about, and I think it's important that we talk about the diagnosis. I mean, what non-Alzheimer's, non-stroke causes are there out there for dementia?
There are different types of dementia. So, there's a Lewy body type dementia, which is one that has an association with Parkinson's disease. In fact, increasingly there's a conversation about it just being a part of a spectrum, whether or not there's a primary movement component to it or a primary dementia piece to that. There's frontal lobe dementias, which generally you'll see earlier in someone's life.
Used to be called Pick's disease.
Yes, yes.
And it's frontal lobe, so the implication is how does it manifest itself different than Alzheimer's, for example?
Well, Alzheimer's is going to be the slow loss of memory, I think is a fair way of describing it. Or if you're going to look at a graph, it's going to be kind of the slow slide. Frontal lobe dementias, I think a lot of times you see folks, and it's the frontal lobe. It's what kind of controls our behaviors and responses and impulse. So you start to see significant changes in personality and changes in behavior, apathy. Some folks become very hyper-oral. They'll start eating and they won't stop eating. And it's difficult for families because you have someone who used to be a certain way, and it's a different person.
I've seen some people develop dementia and they're just happy. And then I've seen some of the nicest people, I think one of them in particular, who became, and who is the most loving, supportive person of her daughter. And then she just became mean, and the daughter took the full brunt of her anger at every turn. Any comment about that?
That's the unfairness of the disease. In what I do, I probably don't see a whole lot of the happy folks.
The happy ones are fine.
Yeah, they're doing great. Well, great in quotes, but I see a lot of the folks with those disturbing behaviors that are outside their norm, and then involved with families and how you respond to that. I mean, how do you? It's amazing. You can have family members lose a majority of their working memory, but they can still poke and twist when it comes to personal insults like the best of them.
Yeah.
And oftentimes it's worse because the filter's shot.
Yeah.
So you get some pretty rotten stuff sometimes, and it's hard to remember that that's the disease process.
Yeah. I've had people present with paranoia, fear that somebody's plotting against them, and what happens is they're losing their memory. They're thinking people are hiding things from them. And of course, then the family has to start plotting against them to try to figure out, keep them safe.
Right, yeah, it's almost self-fulfilling to a certain extent.
Yeah. One of the things that happens when you get that situation with, for example, paranoia or behavioral changes is you can treat it with an anti-psych drug or a neurologic drug that decreases the bitterness, but it takes away their alertness too. What's your comment on that?
Well, the medications we have, they're prescribed because they have side effects, and there's no perfect drug out there. Certainly, there are people that have better responses to certain drugs. But yeah, taking the edge off a person when they're maybe acting inappropriately toward family members, if they're angry with them or upset or other behaviors that are not accepted, then yeah, we use medications that sort of stop that sort of motivation to do those things. But then other motivations can be affected, whether it's getting up and going for a walk or enjoying a TV show, and so they sometimes will just sort of sit in a chair and doze off a lot, and that's an unfortunate side effect that we have to try and balance with the effect that we're trying to get.
Yeah.
You've got to, in those situations, I think it's important to have family directly involved when you're talking about significant side effects of medicines or neuroleptics. Antipsychotic medications carry significant risk, and they carry a black box from the FDA that it does increase, by a couple percentage points risk of mortality. And
Death rate.
Death rate, yeah. And that's scary, but the question is, what is quality as that disease process progresses, and what can we do to improve quality? And with dementia, unfortunately, at some point, sitting comfortably or sleeping more than usual is probably higher quality than the agitation and restlessness that you see without medications.
So this whole discussion brings me to the burden of a caregiver. So I know that something like 80% of the people who are demented out there are at home with his wife, her husband, her daughter, his son. And those people take the burden of that anger, that behavioral problems, or the depression that comes with seeing this happen to their loved one. I think giving as much support to the supporter is very important. Are there other things that we can do?
I think, again, having the conversation is important. I've seen family members, I've seen wives care for their husbands who are, at times they're just downright mean, which is outside what is their baseline. And they've been dealing with that for years. I've had patients' wives. They stay dressed. They go to sleep fully clothed because nighttime awakenings are so random and potentially so dangerous. They want to be up and ready to roll right away. That really impacts how a person does. And you talk about secluding yourself from other friends and families, and I think there is a certain amount of embarrassment that happens with dementia also, because you can't go out to a restaurant at some point because there's risk of potentially something embarrassing happening, and unfortunately that does happen. So you see people get more and more secluded as time progresses.
The family, the support person.
Yeah.
I think that the roles in our society are kind of the issue here, and to a certain extent I care for my wife and my wife cares for me, and if I try and be a doctor to my wife, it does not go well.
No.
And she doesn't listen to me. She listens to me like a husband.
Yeah.
So she doesn't listen to me sometimes when I say things that are a medical opinion.
Yeah.
And at some point, it does cross the line, right? As I age and I need more help from her, I want her to be my wife, not my nurse.
Yeah.
And that's a hard thing. Where is that line? And it's really hard for me as a physician to tell a couple that the line is here and you need to get more help at this point. But I also like to remind them that you need to be a spouse and not a caregiver, because we have professionals for that when it's appropriate.
I think people need to have permission to say, okay, this is beyond what I can do, and maybe I'll take a week break and you can go to the assisted living for a period of time, and then I can decide whether we're going to try it again, or maybe we'll just do 1 day a week. Or I think caregivers need to realize and to have permission to do that, because if they burn out, then no one's benefited from it.
And they do burn out.
They do burn out, don't they? I've seen it too.
Yeah. What I tell patients and families oftentimes when the news is negative, when we're talking about changes in environment or living or going without the keys to the car, is I tell them, blame it all on me.
Yeah. It's that.
You're supposed to be the daughter or son or wife. You're on their side when it comes to this. Blame it on me. Tell them that I'm heels dug in, and I absolutely won't let it happen.
Yeah.
And that is that. Again, if we can set things up where families be families, and I think it's a really good point, then it works well, because then you still have that support system around you.
I think, though, one of the difficult times with memory loss is early on. And it's hard to know when it's early on, and then there's maybe some behavioral things, but just really don't even know that you've got the diagnosis. And of course, sometimes I see families coming in and saying, take his car keys away. He's a danger to everybody in the road and da-da-da. And in my philosophy, and you guys may disagree with me, take care of the worst, but My philosophy is that they're reasonably competent. I don't take away that car until they are not competent anymore. Now, I will say to them, you're competent. I'm not going to take that from you and say that you can't write a check, make a will, make medical decisions. I'm not going to take away your competence level. You decide if it's dangerous for you to drive. And if that doesn't happen and you're seeing dangerous things happening, then it's my role to say to them, I'm going to take away your competence unless you hand me your keys. Sometimes I'll say, you've got to go to Sioux Falls or Yankton or Mitchell and get a driving evaluation. Yeah. And they'll decide. And I take it, then family's out of the burden. I'm off the burden. The police chief, who's been involved with this already, is no longer burdened by this. So,
yeah, it becomes performance-based, right?
Yeah.
So you go do an occupational therapy driving test. Like,
yeah.
You know, if you want to drive, that's fine. Go prove that you're safe. If you're safe and they give you the thumbs up, then thumbs up from me too.
Yeah.
And I've seen a fair number of patients in that situation say, I don't need to drive.
Yeah.
I'm good.
I'm good.
They might know what's
I think
what
they
the
do. I think a lot of times they do. And I've had lots of conversation with patients who actually understand why the conversation's happening. But it's such a piece of kind of who we are, is that independence and driving and control that is slowly chipped away as these dementias progress.
Yeah. I'll give you the other side of it. I had a mid-80s older woman, kind of crumped over little old lady, looks just like the drawing of a little old lady. And she drove to my office, and she was mad as a wet hen. She had been told by her minister that she should stop driving. And she's the one who picks up all the other little old ladies, and they all drive down to the club where they play cards every morning, and then again in the afternoon have treats and coffee. So anyway, I tested her antegrade memory, her new memory. She could remember a new thing. She was competent. There was no question about it. She might have been a little angry, but she was a very competent lady. And I said, nope, you're gonna keep on, you decide, if you think you're hurting people, don't get out on the highway, stay in the small town that you live in during the light of the day and not during times when kids are getting out of school and, do these things. And she did. And she lived another 5 years and drove those ladies around town for a good while and switched churches and left her big amount of money to a different church. Just thought I'd bring that up. I thought
didn't get any accidents or anything.
No.
So, yeah.
Well, I think it goes to, I have yet to run into anyone who likes being told what to do.
We want our
from
independence.
a doctor, minister, a spouse, no one likes being told what to do.
No.
Yep.
And you run into that often as dementias progress.
We need to respect their autonomy, their freedom to choose as much as we can for as long as we can. And then when the time is right, it goes away.
Yeah.
Some people feel they do not want to know that they may have dementia, but there are good reasons to find out early to prepare for the future.
We really advocate for an early diagnosis because there are a lot of things that you can have a say in early on in this disease. You can decide about how you'd like your care to look as the disease progresses. You can decide if you want to move closer to your kids and where they might live. You can decide if you want to take that big trip that you've been putting off. But more importantly, it also leaves you more eligible for if there are any clinical trials in your area. A lot of times that has to happen early on in the disease process. Again, just really knowing where you are health-wise, making changes where you're able, maintaining a healthy weight, again, eating healthy, getting good sleep and staying active both cognitively and physically, really we believe can go a long way in preventing the cognitive decline. Just last year, there was a new study released that talked about the importance of maintaining a healthy blood pressure. 120/80 is really the critical number where if you stayed at that level, you saw a decrease in the risk for cognitive decline. The only way we're going to break down that stigma is if people learn that this is a disease just like any other brain disease that you might have that deserves being talked about, and so that we can address it. And I think that also will help eradicate some of the isolation that goes with the disease, with caregivers and with the people living with staying shut up in their homes and not really getting out. We see 40% of people who are caregiving actually die before the person living with Alzheimer's disease, because so often that takes a toll on their own personal health. So, making sure they're keeping up to date on doctor's visits, but even getting out to be with friends, doing what they love most. If it's a day at the spa or getting your nails done or even coffee with a friend can really make a big difference. And it can also allow them to come back with fresh eyes and be able to begin that caregiving role once again.
This is your program, and your questions are key to the direction of our discussion. Please call in your questions to 1-888-376-6225 or send us an email to ask@prairiedoc.org. She said something that I thought was really good: coffee with a friend. I can't think of anything that is hardly better. They say that you can do quiz questions, you can do crossword puzzles and this puzzle and that puzzle to keep your brain sharp. But there is one puzzle that you can do frequently that's harder than any of them and is more important and probably does the best job, and that is a conversation with a friend. So I'm going to ask your response to that. What do you think?
Yeah, conversation is a huge part of our brain, whether it's facial recognition and reading a person's nonverbal language, and then also the verbal language and how a conversation goes back and forth, and then especially if you're opinionated and you get into a discussion on the president, or that's really stimulating a brain, and it keeps us sharp and engaged in life, and that's how to stay
or any other topic.
Yes.
Right. Yes.
Or religion.
Keep
or
your,
religion.
Right. Keep your friendship. That's important too.
Be careful too. That's all
intake.
part of the complexity of a conversation.
Exactly. Yeah. Exactly.
Yeah. So I love that particular idea. I think if you like to do puzzles, do them. But I also think that there's something about connecting with people, and that's one of the things that prevents vascular disease and heart disease. That spiritual connection that we have with other individuals, plus that conversation is a complex brain teaser. Mm-hmm. Yeah. Part of the things that I wanted to ask about is that, of course, we've talked about frontotemporal and we've Pick's disease and the Lewy body dementia and Parkinson's disease and Alzheimer's disease being 60% and vascular being 30%, and then there are all the rest of these weird things.
And some overlap between all of them, too.
Yeah. But there are non-dementia-inducing things that can make your brain break down so that you look like you have dementia, but it's treatable. We need to make sure that when we're seen by the neurologist or the psychiatrist or your general internist or your family doc or your PA and NP, that workup is done. What would be the proper workup for someone who has early issues of memory?
Well, the general workup, it varies with what's coming in, number one, but most people need at least a blood count, B12 level, and thyroid level, because those can be just memory. That's all they have as far as symptoms, and so you really have to check. Everybody with memory problems gets that workup in my clinic, but then if they have a history of welding or some sort of unusual dietary habit, maybe check heavy metal, or if there's a lot of alcohol in their history, really flesh out how much alcohol they're drinking, and is that contributing to their memory problem? Is that, can we stop one of these processes and reverse their memory problem? And that's a key part, because if it's not that, of course it's dementia, and that's not treatable right now, but many of these things are.
Reversible, right. Yeah. I think the big one that I've seen is the tranquilizers, and antihistamines. And blood pressure pills. What do you think on that?
If you think about it, if you think about Ativan or Klonopin or those benzodiazepine class medications, they hit the same receptor that alcohol hits. That's what they do. So, you know, the same risks that occur with alcohol use occur with use of those medications too. If you've been on them for years and you stop them too quickly, there's risk for withdrawal and risk for seizure.
Oh, yeah.
And they do impede how people respond to others. So, you know, those medications at some point were started because likely there was an anxiety issue going on and they were helpful. As people age, though, their bodies metabolize differently and slower, and you can actually get kind of the opposite response. You know, what used to be calming now is stimulating, and you go from kind of a laid back to pretty agitated.
Situation.
And then there's more and more evidence lately that indicates those medications, there's a significant correlation between those medicines and dementias. And that's to include medicines like Benadryl and the other anticholinergic medications also.
Yeah.
Yeah, the sleep aids, you know, oftentimes can be
The worst culprits.
yeah, and then people get a little bit confused when they wake up at night, and if they've taken a strong tranquilizer and or hypnotic, one of these medications that help you sleep, it really
Ambien.
can. Yeah, Ambien is a
the
strong
worst.
one. Yep.
Well, I can't say enough against those medications, particularly if long-term potential for dementia is a part of them, and they are so dependent causing. And then if you get on them and you can't get off of them because when you stop them you have withdrawal anxiety. Enough said. We have questions. Thank you for the questions. A caller from Alcester asked, what are some ways you can prolong the life of a person with dementia?
Oh, I think just you know, again, the social interaction is a key part of it, and stimulating multiple parts of their brain with a good conversation is just, it engages a person and puts that twinkle back in their eye,
Yeah.
and I think that's a big part. Just general medical health. If it's a vascular dementia or there's vascular disease, of course, then you know, making sure those risk factors are managed, and
An exercise program,
Exercise is
eat less
good.
calories, you know, a balanced diet.
Everything that I don't do.
All
I think we have to meet folks where they're at.
yeah.
You know, and it's it's what stinks about dementia is, you know, it starts and we're worried about kind of that small loss in the beginning.
Yeah.
And as it progresses, you know, we're way down here somewhere, and we wish we're back here when it first started. You know, I think you got to meet folks where they're at. I think a consistent environment goes a long way.
A consistent environment.
Because change is difficult, and I see it oftentimes when folks move from home to a facility. Is that new environment
Blows them out of the water.
Oh yeah, it's and it makes a lot of sense, right? You've been on the farm for 70 years.
You know exactly where the toilet is. You know
Right.
exactly where the breakfast and when breakfast will be served.
And a lot of times you see folks that eating, bathroom, showering, all that stuff, it's almost like on automatic. You change the environment,
And then they
and you
stop.
see dramatic loss in functioning too.
That's amazing. The caller from Brookings asked about the difference between a mini stroke and early dementia.
Well, early dementia is typically defined as dementia that has it sets off in earlier life, under 60. A mini stroke is a problem where typically the language is that they have a stroke that goes away, so their arm becomes weak or they lose their vision. Memory actually isn't a problem in stroke. Typically, people can become confused and use the wrong words or maybe can't talk, but they don't typically lose memory. There is something after a stroke where you seem to lose some cognitive reserve and don't remember things as well as they used to. But they're very different processes. In one hand, people that have a lot of strokes and vascular disease do develop a lot of memory problems as they age, but it doesn't happen like a stroke does, where it's all of a sudden. It's sort of just like dementia happens. It goes slowly and gradually, yeah.
I've heard that same thing happens with prolonged hypertension. A person, big group that all had hypertension. Half of them were treated, the other were left alone. It was this kind of borderline hypertension. Mm-hmm. The people who were left alone 10 years later had memory issues compared to the treated ones. Do you think that's true?
Yep. Yeah, I don't think that I read that study actually today when I was kind of
thinking about
reading
the show.
up. Yeah. And
that's good.
Yeah, I'm still a student at heart, But but the difference wasn't that
Huge.
much. I mean, it was a large study, so there's a lot of people that they did study, so they did see a small difference, and it was real, but was it significant? And
Is it worth a pill?
is it worth the pill and
medical.
the side effects and everything? And I think you have to go to your doctor and talk about it, and eventually, come to a decision. And everybody's different, so you have to kind of make that decision with your doctor.
Yeah. A caller from Brookings asked about the difference between Alzheimer's and dementia.
It's a good question. Dementia is the umbrella, and then there are different categories of what types of dementia that fall underneath that. So Alzheimer's is a type of dementia that has a specific clinical look to it, and then you've got your frontal lobe dementias, and you've got Lewy body type dementias, and then
Head trauma dementia.
head trauma, TBI dementias, and vascular dementias, and all of those are considered dementias, but they're specific categories of dementia.
We have a caller from Sioux Falls, relative with frontotemporal dementia. Positive person, does progressive affect that? How long will it take to progress? I have a relative, very positive person. As it progresses, will he become negative? So, and how long will it take? That's the question.
That's a challenging one.
Yeah, I
Oh,
think
you don't
that-
have a good answer, do
Yeah,
you?
there really isn't. That's what's difficult
Frontotemporal is
about
a
it.
really,
Yeah.
and the difference, it's interesting, one of the differences that I've been able to glean from all of this is Alzheimer's dementia people can walk normally. Their gait is preserved until way late. Whereas almost all of the others, they have some kind of gait abnormality. Am I right on that?
Yeah, I think that's pretty common. Pretty easy way to think about it.
Yeah. So I have this question. So I read in not too distant past that in some people who have Alzheimer's disease, when you do the autopsy, you find neurofibrillary tangles and senile plaques and this classic pathological findings. And people who've had strokes on the autopsy, they find little lacunar openings where the strokes had occurred, and you can explain it that way. But sometimes people who have neurofibrillary tangles and senile plaques and the perfect picture of Alzheimer's didn't have dementia. And that sometimes the people who had the perfect picture of Alzheimer's had lacunars. In other words, some people think that they might be just really one thing, or there might be a lot of halfway there or combination. Now can you put that into a better language, and what's worth saying to the people? Take home.
It's challenging. We have what we call a clinical evaluation for a patient. So they come in and sit down in front of us and have certain features that we kind of put into a slot that says, well, they're not taking care of themselves anymore. They're not bathing. They don't care that their buttons are not lined up on their shirt, and we say that's more of a frontotemporal problem. And then another person is very pleasant and put together, but they can't remember anything about where they are, and that we say, well, maybe that's more Alzheimer's disease. And so you have these clinical pictures that you have, but yeah, the pathology, when you get into the brain, it's not so clear cut. I mean, there certainly are tendencies for those people that have a diagnosis of Alzheimer's disease from the clinic to have a biopsy or an autopsy that looks more like amyloid plaques and neurofibrillary tangles, but it isn't 100%, and that's why the medicines that we use, sometimes they work and sometimes they don't, and I think that's probably because we're talking about different, even Alzheimer's probably has different pathophysiology, different reasons and causes on what's happening, and that's just the way it goes.
When we get back from this roll-in, we need to talk about the medications that we use specifically for dementia. Don't let me forget. It hurts to see a loved one drift away with dementia, but heartfelt caring and finding what is the best care generates the best quality of life possible.
She did not know where her car was after she had gone to the grocery store. so my son had to go down and find the car for her. Secondly, she decided that she did not know how to get home from different places, so she would follow me home with her car. And there were a number of tests, for instance, drawing a clock, and that more simple things like that she could not do. It just progressed to the point where it was difficult to help her, and I felt sometimes that she may be a little more comfortable in a nursing home because they were able to help her more than I could. The workload was at times intense because it was not only during the day but at night. She might get up and start wandering. I think friends have been very supportive, and the work that the people at the nursing home have done and visited with me, I think those were very supportive, and they were telling me that she was fine, you know, they were taking care of her carefully, and that kind of thing was important. The advice for the spouses is that we certainly understand their concerns, and that there are a number of people that can help and provide help, that they should continue to look into that, because it's important that the person with Alzheimer's is as comfortable as they can be.
Dwayne Sander, who of course helped develop Daktronics and who was the head of the what department in the engineering department in SDSU, no dull thud, you know, is also one of the kindest, caring man I know. And his wife Phyllis was she and I did continuing medical education for 30 years together at the Brookings Hospital. We had 1 or 2 hours of CMA every week. Just an amazing lady. Breaks my heart. But Dwayne is happy with that. I did promise that we would get back to the question about treatment, and here is somebody from Rapid City wants to know if there are any over-the-counter medications that help with memory loss early on. So a lot of people sell treatment for Alzheimer's disease out there, herbal treatments and so on and so forth. Is there any herbal, non-prescription medications that are of any value, aside from maybe B1 and B12, if there's a deficiency there?
No.
That's a good answer. I don't know of any either.
You know, you could maybe make an argument that perhaps melatonin, when you get into the sleep disturbance that occurs later in dementia, can be helpful in regulating that circadian rhythm. But outside that, I don't think so.
Do you?
Well, B12 levels, they can be normal, and you can still have memory problems. And so
I put anybody with memory problems on B12.
I think it's not a bad idea. I mean, you can check it, but even if it's 400, I agree. I still put people on B12. It doesn't. You can't get toxic on it.
No.
So
you pee it out if it's too much.
Exactly.
So let's talk about treatments, though. I mean, prescription medications. There are 2 groups of medications that we now use to help people with Alzheimer's. They're very expensive. And do they help much? And do you use it for a long period of time, shorter period of time? What's your take on that?
Well, I think there's a role for it. So early on, I think that there is some benefit because it does preserve some level of functioning. I think if you go back to the big study where the FDA approved Aricept, it showed that, I mean, the end result literally was it kept someone out of the nursing home for 6 months. Like that's what the medicine did.
Yeah.
As dementia progresses, however, I think there is a role for those medicines when it comes to behavioral disturbance in dementia.
Yeah. And the second group, like Namenda, so Aricept and its congeners, and Namenda and its congeners, you add those later on, but first start with Aricept. What is your take on that?
Yeah, I think that there seems to be responders and non-responders, and of course the big FDA study to approve Aricept or donepezil, that it was a modest response. I didn't think it was that impressive, and we talked about nutrition and diet, and it certainly one of the major side effects is abdominal cramping because it's a cholinergic, and so what I monitor after I put somebody on a anticholinergic is or anticholinesterase is their weight. Right? Are they losing weight?
Yeah.
And then if they are, I mean, that's more significant than what benefit they're probably going to get from the medication.
Yeah.
So I think you just have to monitor it with your doctor if you're put on one of these medications.
I saw the original article come out in the New England Journal of Medicine. I had it. I'm reading every day. Wow, we've got a drug, 5 milligrams, and then they went up to 10 milligrams, and it made very little bit of a difference. Mm-hmm. So, of course, all the pharmaceutical industry pushes everybody to 10. I went with
20, now 23.
Oh, is that right?
Yeah.
It's 5 milligrams. That's where the data is.
Yeah.
Good enough. I buy a 10 milligram, have them split it.
In that study, there was a small group of patients that did exceedingly well on that medication. And I think there's more and more evidence out that the acetylcholinesterase inhibitors, the donepezil type medications, are especially effective in Lewy body type dementias.
What is Lewy body type dementia?
Lewy body dementia is a dementia that's kind of related to Parkinson's disease. It's interesting in that if someone has Parkinson's disease for over a year and then suddenly they're having a dementia issue, it's called Parkinson's disease with dementia. If you have the memory loss issue and then some correlation with some movement difficulty or movement changes, then it's considered Lewy body dementia.
But it's probably the same thing.
Yeah, I think it's the same thing, but I mean, you see autonomic instability. The big one is visual hallucinations, and I think studies indicate that actually improves with medicines like donepezil.
Yeah. All right, we've got 4 minutes. We've got like 10 questions. Let's slip through these quickly.
Sounds good.
A man from Rapid wants to know if there are any over-the-counter, we did that. What effect can sleep apnea have on dementia? That's up your alley.
Yeah.
Jeff?
Well, of course, you don't sleep well, you get a little grumpy, and then can't really remember as much. And I think over time, there's a lot of risk factors that go into untreated sleep apnea, and weight gain, and maybe some hormonal abnormalities, and it all kind of adds up, and it can result in some memory trouble. People
who have atrial fib and people who have memory loss all get a sleep study from me. So if there's memory loss or new atrial fib, get a sleep study and then have Jeff check it,
Happy to do so.
A woman from Sioux Falls is wondering about chemotherapy affecting short-term memory. I've been on chemo off and on for a lot of times. I don't know that I've noticed a lot, some, but not a lot. What's your take?
I think it can without question. If you think about what those chemotherapeutic medications are doing, it can cause damage and it can impact memory. I think the question is whether it's a long-term dementia process that's going on. I don't think that is the case.
All right.
I agree.
Electroconvulsive therapy. This is your bailiwick, Bob. For people who have severe depression, it's non-medicinal. It really does work for for depression. Does it cause memory loss long-term, like who flew over the cuckoo's nest baloney?
In a small percentage of patients, it can. It's interesting. You can have someone with what's called pseudodementia, which is basically a depression that's so severe that it looks just like dementia.
Yes.
In those cases, you do ECT, and you have someone completely recover all of their memories, and they act like you or I, and they're back to driving bus or whatever they're doing before they got sick. So I think there's a role for ECT. It's a fantastic treatment for depression.
Bingo. Say that one more time. Fantastic treatment for depression. And the minimal side effects.
It's still the best treatment for depression that there is. It's better than any medication that we have right now.
Okay. Jeff, alcohol caused dementia?
We talked about this earlier, extended alcohol use does seem to take its toll. It's a poison, and then the brain cells slow down with it, and it seems like some of them don't recover once you do.
But a lot of it is B1 deficiency, right? Thiamine deficiency. They come in with alcohol, abuse. You give them thiamine, and they blossom again.
Yeah, I think there's an element to that. The nutrition is a big part of it, and if you come home and you have a six-pack of beer, you probably don't have a big dinner. And if you don't have that dinner, there's no thiamine in beer, and so then it's nutritional as well as alcohol exposure.
Okay, can right temporal lobe cancer lead to dementia?
I wouldn't say it would lead to dementia, but certainly the right temporal lobe is important for, processing and nonverbal language skills and some auditory stuff as well. And so some memory problems might come from that, but it wouldn't be necessarily from called the dementia.
How do I lower my chances of getting dementia? How do I prevent it? Let's just go over it again.
Well, I think exercise and diet are huge. And I think the more people look into that, they're more recognizing that these dementia processes probably start well earlier than we can actually recognize at this point. And taking care of your body is a good thing.
And I think less calories, whether you're heavy or thin, doesn't matter. Less calories, and a conversation with a friend in a spiritual sense. We got. How do frontotemporal dementia one more time? Can you explain it?
So frontotemporal dementia is a dementia where a region of the brain becomes selectively affected, and it's the frontal lobe and the temporal lobe, and so people will become, their personality will change, and we don't know why it's that subset of brain, but there is a reason for it. The pattern is very common. It's
something's wrong up there.
Yeah. And on imaging, you see that the frontotemporal lobes have atrophied. They've shrunk quite a bit. I mean, that's noticeable over time.
From some cause.
Yeah.
Very good. Thank you, guys. And now for the winner of tonight's Prairie Doc quiz question. The most common cause of dementia is 1, vascular-induced dementia, 2, Alzheimer's disease dementia, or 3, senile dementia. Of course, there's no senile dementia anymore, right? I mean, that's not a diagnosis anymore. The answer is 2, Alzheimer's. 60% of all dementia is Alzheimer's disease. It was Gloria Jonathan from Viborg who answered the question correctly. Thank you, Gloria, for participating, and a book will be in the mail to you soon. We'll be right back after this.
For nearly 2 decades, the Prairie Doc organization has endeavored to enhance health and diminish suffering by providing useful information based on honest science in a respectful and compassionate manner. Health professionals volunteer to answer your questions each week, creating a vast Prairie Doc library of medical information available to you and your family 24 hours a day. Make sure you don't miss a thing. Follow the Prairie Doc on Facebook and YouTube for free and easy access to the entire Prairie Doc library.
Over a 6-month period, a 78-year-old businessman with clever wit and superb leadership skills became less able to talk. He gradually became more confused, lost his ability to learn new things. In the end, he lost his capacity to swallow well and started inhaling some liquids and food until finally, pneumonia gently shuffled him off this mortal coil. Dementia is a progressive deterioration of intellect, memory, and social skills which, by definition, interferes with normal activities and relationships. It's an umbrella term which includes various types and causes. Alzheimer's disease and vascular disease caused by small and large strokes make up the lion's share of dementias. Other rarer forms of dementia include frontotemporal dementia, Lewy body dementia, traumatic brain injury, and various combinations of any of these conditions. Classic Alzheimer's accounts for more than 60% of dementias. Early symptoms include recent memory loss or loss of the ability to learn a new thing. Until very late in the disease, people with Alzheimer's usually retain the capacity to walk normally. Gait abnormalities, by comparison, are usually found with most of the other causes of dementia. It's important to note that some people can have a gait abnormality without dementia. If you can, walk a mile a day, by the way. The prevalence of dementia increases with age. 5% of those aged 71 to 79 have dementia, while the incidence increases to 38 to 50% in those 90 or older. But this also means more than 50% of the very old do not have dementia. Your care provider should evaluate and treat, if apropos, some often reversible or temporary causes for dementia-like symptoms. These include depression, low thyroid, certain infections, multiple sclerosis, low blood sugars, too low or too high sodium or calcium, chronic alcohol use, malnutrition along with vitamin B1, B12, and D deficiency, dehydration, bleeding under the lining of the skull of the brain, poisoning from heavy metals or pesticides, smoking, high levels of carbon monoxide, check your furnace, low levels of oxygen, moderate to severe sleep apnea, brain tumors, and any major medical illness, and last but not least, side effects from certain medications, especially tranquilizers like Ativan or Xanax. Look at that list again and make sure these conditions are considered when you or your loved one is first being evaluated for dementia. Beware of scammers who are thick as thieves looking to sell you false treatments. For more credible information about dementia, go to medlineplus.gov. There's no changing the devastating nature of dementia, but knowing all about it can help. Well, a big thank you to our guests, Bob and Jeff, for volunteering to come to our studio in Yeager Hall on the campus of South Dakota State University. Their insights into this very serious condition gave us all valuable information. Remember, we are getting into the annual flu season. It really isn't too early to get the flu shot or get it soon. It is important not just for you, but to help protect the very young, the very old, those of us who are immunocompromised. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
Cancer can affect any part of your body, soft tissue or bones. It can be relentless and surprising where it shows up. Common and uncommon types of cancer and what to do about them. Next time, On Call with the Prairie Doc.
For more than a decade, Dr. Holm, in his role as the Prairie Doc, has emerged as a leader of healthcare education and communication in South Dakota and across the country. Every week, Dr. Holm and other medical professionals volunteer many hours to share science-based truth about healthcare on public television, on the radio, in our newspapers, and online. And best of all, everyone has free, easy access to the entire Prairie Doc library. Hi, I'm Jennifer May of Rapid City. As a board member of the Healing Words Foundation, I ask you to consider making a donation. Please help us continue this important work. Go to prairiedoc.org and make a donation today. Thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
and with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
Avera Heart Hospital,
Dakota Allergy and Asthma,
Fishback Financial Corporation,
Vance Thompson Vision,
Urology Specialists,
Brown Clinic,
American Academy of Family Physicians Foundation and the South Dakota Academy of Family Physicians,
Black Hills Medical Society,
Aberdeen District Medical Society,
3rd District Medical Society,
7th District Medical Society,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
Aberdeen Asthma and Allergy,
and Swiftel Communications.